Hello, everyone. Hello, everyone. Welcome to our third installment of the webinar for the Women in Dentistry series. For those of you who don't know me or who haven't logged in yet, my name is Dr. Effie Hapsha. I'm a prosthodontist. I practice in Toronto, Canada, and I'm the founder of Women in Dentistry Work-Life Balance, a group we started over 10 years ago. We are very pleased to provide you with continuing education throughout this time via webinars. During the year, we normally have seminars that we hold in person and live. We have a lot of really great things as part of our community, including a journal, a publication that we put out twice a year. And the most recent one is entitled, Can Women Have It All? So it's a really great way to connect. So I encourage all of you to join us, to follow us on Facebook, to follow us on Instagram, like us on Facebook at Women's Dentistry, and we look forward to connecting with you on our social media platforms. So for today, we are very excited to have the very, very talented Dr. Sonia Chopra joining us today on our panel. Dr. Chopra will be talking to us about managing endodontic emergencies, and I'll just tell you a little bit about her before we get started. So Dr. Chopra came very highly regarded from a well-known endodontist, so we connected initially about a year ago. And to tell you a bit about her bio, her history, Dr. Chopra is a board-certified endodontist practicing in Charlotte, North Carolina. She is the creator of eSchool, an online education forum for general dentists worldwide, sharing knowledge on how to perfect endodontic skills, improve diagnosis, and deliver compassionate solutions by considering whole patient care. She's also the founder of Ballantyne Endodontics in Charlotte, North Carolina, where she is a leader, a teacher, a mentor in the local dental community. Through all aspects of her work, she emphasizes the importance of helping patients understand the why and how of their procedure. Dr. Chopra is a director for the College of Diplomats of the American Board of Endodontics and on the CE committee of the American Association of Endodontists. And if that wasn't enough, she's a wife and a mom of 3 kids. So we welcome Dr. Chopra to the event, to our webinar. Just a little bit of housekeeping. We have turned off the chat feature, but the Q&A feature is on. So please feel free to submit your questions as Dr. Chopra proceeds with her webinar, and we'll answer them. We'll have her answer them at the end of the session. So I'm going to sign off, and I leave you to enjoy Dr. Chopra's webinar. So welcome, Sonia. We're excited
Thank
to have you.
Thank you so much, Effie. So happy to be here.
My pleasure. My pleasure. So I look forward to learning all about endodontics.
Awesome.
Enjoy.
Thank you. All right. So I am going to share my screen here and kick this off. Oh, sorry. Okay, there we go. All right, everybody. Thank you so much for being here. I want to applaud each and every one of you for taking time and using this time that we have right now to growing yourself and really taking your knowledge to the next level. This is a topic that I'm really passionate about, managing endodontic emergencies. It's not just important right now. I think this topic is important whether there's a pandemic or no pandemic. And the main reason is because a lot of us we just need to learn how to triage properly. None of us are sitting around waiting for a patient to call us for an appointment, for their emergency. We all have busy schedules, and we all have to know how to take care of that time and to still be able to provide quality work for our patients. So this is going to be true even when we end all of this craziness. And so I want you to just carry this information with you forward. So just a little bit about my history. I am a board certified endodontist. I went to dental school at the University of Maryland, where I graduated in 2003. I did a general practice residency in Brooklyn, New York at the Long Island College Hospital. I worked as a general dentist in New York City from the years 2004 to 2006. I realized that general dentistry was just way too hard for me, and I needed to focus on one thing, so I applied to Endo, and I graduated from Nova Southeastern University in 2008. I then moved to Charlotte, North Carolina, where I started my practice called Valentine Endodontics. And that was in 2008, which was the last recession we had. So I have complete hope and faith that we will come out of this current situation with a positive outlook. All right, so today I want to just go over my objectives with you. I will help teach you a very simple system for your diagnosis. I want you to understand how your diagnosis will guide you through your entire endodontic process. I want to teach you how to triage the right way, and I'm going to teach you some of my pain management hacks, and I want to treat you, I want to show you what treatment must be done in every situation in order to get your patients out of pain, and also make sure that they stay out of pain, because we don't want our patients to keep calling us back over and over and over for the same problem. Okay, that's when our patients start to lose faith in us. So that's a really key element here. I also want you to understand how to follow up with your patients. We as dentists really need to know what's normal and what's not normal for our patients after they get a particular procedure. And of course, we want to make them feel loved. And if any of you have followed me, you will know that I love to teach through tooth stories. So I'll go over a few of those. And then we can kind of brainstorm a little bit of how we can do this remotely during this new, unique time. So I will always start by saying that diagnosis is king. We cannot do anything in endo without a proper diagnosis. And when you know your diagnosis, and you know it so well, this diagnosis is going to make you understand how to anesthetize your patient, how to treat that patient, what medications they need, and how to follow up with that patient. This is so critical. And I know that so many people like to skip over this step. But if you know your diagnosis, everything else should be a walk in the park, okay? It's so critical to really have a true understanding of that diagnosis. So what do I mean exactly? Well, I'm going to take it back to basics. We all learned in dental school what our pulpal and periapical diagnoses were. And if you don't remember, these are the accepted definitions currently. Anytime you do a root canal on a tooth, you need to have two diagnoses. You need a pulpal and a periapical diagnosis. If you don't have both of those, then you have not warranted that root canal. Okay, so I'm going to go over these and then make you understand which ones actually require emergency endodontic care. Okay, I'll go over these briefly now and then again in the presentation. So obviously we know what a normal pulp is. The normal pulp is normal, right? So we don't really need to focus on that one. Reversible pulpitis is when you have a patient who is having some thermal sensitivity, maybe because they have some decay. That decay is relatively shallow, and once you clean that out, the patient's symptoms reverse, hence reversible pulpitis. It also could be because maybe the occlusion is high and they were having thermal sensitivity, and once you relieve that occlusion, that pulpitis resides, okay? Then we have asymptomatic irreversible pulpitis. This is when your patient has decay into the nerve and they have no pain. It's asymptomatic because there's no pain, and it's irreversible because that bacteria has already gotten into the nerve. And then we have our symptomatic irreversible pulpitis. That's our hot tooth. That's the one that we always can think about when we think of a toothache. That's the cold lingering pain, the spontaneous pain, the pain that's waking us up at night. That's your symptomatic irreversible pulpitis. And then we have the necrotic pulp. That's obviously when there's no response to cold and the nerve has died. So that's all inside your tooth, but all of that has a response on the periapical region. And so there's also an effect there, and that's what we're going to categorize with the periapical. With the periapical, we have, again, a normal periodontium. There's no pain to percussion. PDL is normal. There's no radiolucencies in the bone. It's absolutely pristine. Then we have the asymptomatic apical periodontitis. This is when you have a lesion, but there's no pain to percussion. And it could be as simple as a thickened periodontal ligament as well. Then we have symptomatic apical periodontitis. This is when your patient has pain to percussion. And then the acute apical abscess, where the patient is physically swollen and there's pus present. And then there's chronic apical abscess, which is the presence of a sinus tract. And sometimes the sinus tract can be sneaky. Sometimes it's draining through the sulcus. So that also counts here. So you'll notice that I've highlighted some of these in red. And those ones that I've highlighted in red are the ones that have the capacity to become a true dental emergency. Anything else can be really medicated, either with analgesics or with antibiotics, especially during this time, okay? And I think it's important to note that even on a normal day, when we are all functioning the way we normally, what we remember, when you are either treating that patient or maybe you are sending this patient to a specialist, some of these patients do not require same-day treatment. You can medicate them with some pain meds and hold them over to a time when you actually have time in your schedule to provide quality care. So remember that, okay? There are different ways to manage these patients and still make them feel loved. Okay, so your system for endodontic diagnosis is very, very simple. I do these tests on every patient that I meet, and I really encourage everyone to do the same for every emergency patient that you meet. I do a lot of probing, okay? And yes, I'm an endodontist who likes to probe. I love my probe. It tells me a lot of information. Again, this is where I'm gonna find that sinus tract that's draining through the sulcus, or perhaps this is where I'm gonna find that probing depth that could be related to a crack. Now, usually it's actually that sinus tract that's draining through the sulcus, so don't let some probing make you think that the tooth is cracked. I will typically palpate as well, and I'll keep these at the beginning of my testing for a reason, because as I'm going down this list, my tests are getting a little bit more sensitive. So percussion is next. And again, I'm always starting on the opposite side when I'm doing palpation, percussion, and cold. I always start with a normal tooth, a controlled tooth, before I go over to the affected side. Probing, I just stick to the affected side and make sure I probe the entire quadrant. So if I'm doing tooth number 3, I'll probe teeth 2, 3, 4, and 5, okay? If I have a positive percussion test, I really don't need to do my bite stick. So I won't do my bite stick all the time, but if their chief complaint is that they have sensitivity to biting, and I don't get any sensation from them from a percussion test, I will do a bite stick just to see if I can replicate their symptoms. Heat testing is a little bit more complicated. I think it's a really hard one to test because really the only true way to test this is to put a rubber dam on and to do a hot water bath. And that rubber dam clamp can be really painful and people don't like it without anesthesia. But once you anesthetize, you really can't perform any more tests. So when I do heat testing, I actually just talk about it and I ask them, and typically your patient is going to give you that information in their chief complaint. And then of course I keep my cold testing for last because everybody hates a cold test. And so I want to make sure that they know that my weapons are down after that test is open, all over, sorry. So keep your cold testing for last. And again, always start with a contralateral tooth before you do the affected side, okay? And do it in the same order every single time. And by the time you really get good at this, all of these tests should take no more than 3 minutes, but do it on every single patient. And you'll start to see trends that will just start to make more and more sense the more you do this. All right, so let's go through every diagnosis so you can see what I need to do in order to, again, to anesthetize, to treat, to medicate, and to follow up. Well, all of those things will be addressed per diagnosis in this next section. So irreversible pulpitis, again, is your patient who has pain to temperature. It could be spontaneous and it could be lingering. Now, in this category, you have to remember what your periapical diagnosis is in conjunction with this. So if your tooth has cold sensitivity and percussion sensitivity, you can't do just a pulpotomy. Once there's percussion tenderness, you have to do a pulpectomy, meaning you have to complete your instrumentation on that tooth. You don't have to finish the root canal, but you at least have to get that pulp out and you at least have to clean it to like a 25 rotary or something like that. Now, if it was just cold sensitivity, a pulpotomy will be sufficient. And I think that's really important to know because some people are not comfortable doing the endo. They prefer to just do the pulpotomy, get the patient, stable, and get that urgent care out of the way, and then refer that to the specialist. So, just remember that you don't have to do the full root canal. Sometimes a pulpotomy will work. Now, for me, a pulpectomy takes maybe 5 more minutes more than a pulpotomy. So it doesn't really, I don't really do pulpotomies that much. But one thing that you have to be certain of when you are dealing with a vital tooth is that you do have to find every single canal. Otherwise, the patient is going to be in a lot of pain afterwards. And that's a little bit different than if you're treating a necrotic tooth. When your tooth is vital, like an irreversible pulpitis tooth, an antibiotic may not work as well as you like it. And I really don't love to give antibiotics for people with vital teeth. I also know that narcotics may not work for me as well. There's going to be certain moments for certain patients where pain meds are not effective. They just kind of laugh at the patient. And even anesthesia can be difficult. So these are your patients that could definitely become a true dental emergency. But if you think about it, eventually that nerve will die. But we just don't know how long that's going to take. And I know that we've all experienced this because we've all had the patient who had pain Friday and Saturday and even Sunday, and it was the worst pain imaginable. They couldn't sleep for 3 days, but then by the time they see you on Monday, they feel better. Why? Because the nerve died over the weekend. That painful episode was their nerve dying, and by Monday, it felt better. So eventually this pain will go away and it will no longer be a true emergency. I'm not saying to make your patients wait, but I'm just letting you know of the process. Most people start with cold pain, then heat pain, then percussion pain, and then proper nerve death. So the necrotic pulp is the tooth that has no response to cold. This tooth could be have percussion tenderness or no percussion tenderness at all. But now that the tooth is actually infected, because before when we had irreversible pulpitis, that was still inflamed. The itis means it's inflamed, not fully infected. Necrotic pulp means the nerve has died from infection. So now your antibiotic is going to be a lot more effective than if you use it in an irreversible pulpitis situation. Because I know we've given antibiotics in situations and it hasn't really helped the patient. Why? Because the tooth was vital. When you are giving antibiotics for patients with necrotic pulp, clindamycin is a really good choice. That's the one that I prefer, and some people use it 300 milligrams TID or QID. I've always used it QID, but I am kind of testing it with TID. If I can give less, then that's better, in my opinion. There are going to be some differences in the way you want to medicate. My partner, he uses Augmentin and he's happy with that. I personally like clindamycin because I feel like it really gets patients better faster. For a milder pain, you can drop clindamycin down to 150 milligrams, but I'm typically only medicating when people are pretty bad, so I usually have to use 300 milligrams. I'm medicating for somebody with mild pain. Now, once you give an antibiotic to a patient, they should start to see some relief within 24 to 48 hours. Again, I'm not advocating to use an antibiotic for pain. I want you to use pain meds for pain, and I want you to use antibiotics to treat infection. But obviously, there's an infective process going on here, and so you will get a shift in their pain symptoms. When you're treating a necrotic pulp, you need to do a pulpal debridement with calcium hydroxide dressing. So if you just want to do the bare minimum, get that patient out of pain and get them comfortable, and again, get that urgent care done, then the minimum amount of treatment that you need to do is that pulpal debridement. Now, let's say you couldn't find one of the canals. Just by opening the tooth up and adding that oxygen in the tooth and decreasing that bacterial load a little bit is going to function just fine. Okay, that plus an antibiotic will function just fine, which is the opposite of what would happen in a vital tooth. If you're doing an upper first molar and you don't find an MB2, that patient could actually have more pain after you do treatment. So finding canals in a vital situation is a lot more important than in a necrotic situation for that emergency portion of your treatment. So the asymptomatic apical periodontitis, that's where you have a lesion, but you have no pain or no pain to percussion. So I am including this here, not because it's an example of a true emergency, but if you do treat it, it could create an emergency. So a patient could very much well have a post-operative flare-up in this situation. So anytime you are instrumenting a tooth where there's a lesion, you should always, always, always tell your patient that they could have swelling after treatment. The number one reason is because you don't want that patient to think that you induced that swelling. So even though it's painless preoperatively, postoperatively, this patient can shift. And those are the patients that don't really like us so much, right? Well, I didn't have pain until you touched me. Well, if you address that and you manage the patient's expectations, and I'll talk a lot about managing patients' expectations because I think that's really important to alleviating their post-op pain and their post-op anxiety, which could then increase their pain. I think it's really important to spend a good amount of time with managing this. So anybody who has a lesion, I tell them, I said, hey, 10% of my patients, no matter what I do, you are going to swell. Or you could have a lot of pain along the jaw, or biting may be super sore to you. I want you to know that all of this is a part of normal. I don't know how you in particular are going to heal, and this is a possibility. When you let them know that their face could be out to here the very next day, and then it happens, they're a little bit better about it. They're not ecstatic that it happened, but at least you told them that that was a possibility, okay? So if you're treating something that has a lesion, let them know, because this is always a possibility, and it can be really scary for a patient. So that's why I wanted to include it here, even though this diagnosis is not a true emergency. Now, your patients with symptomatic apical periodontitis are probably not comfortable. They're going to have pain to percussion, and they may or may not have a lesion. So not all patients have a lesion with this periapical diagnosis. I typically find that an antibiotic will work here to decrease percussion and biting pain. Sometimes, again, you have to triage within your own practice. And so you'll have to give them an antibiotic, which is good because it's actually going to decrease their post-operative pain in the future. Some people, I look at them, I'm like, man, if I touch their tooth, they're actually not going to feel better. They're actually going to feel worse, because there's a rule in endo. The more preoperative percussion pain you have, the more postoperative pain you're going to have. So sometimes it's better to decrease that preoperative flare-up so that your postoperative flare-up is not as bad. Again, I'm not a big pusher of antibiotics, but in this time, we may have to lean on them a little bit more than we like. Ibuprofen is really good for percussion pain. I don't know if now we have to be careful. I just think right now we need to be mindful of giving ibuprofen and making sure that we're not giving it to people who are symptomatic. I'm seeing mixed things about this right now. I don't know if ibuprofen is contraindicated during this COVID time. It will be more effective for your patients in managing pain. So again, if you are using Tylenol or acetaminophen for your patients, again, you need to manage their expectation and let them know that they're not going to be as comfortable as somebody who could use an anti-inflammatory, and they are going to take longer to heal. So again, remind your patients of these things. After instrumentation, your patients are always going to have more percussion tenderness. And I kind of like to say it like this to my patients. If I were to dig under your fingernail for an hour and a half, your fingernail would be pretty sore. Now, if your fingernail felt like your tooth does right now, and then I dug for an hour and a half, it would be more sore. And when I tell that to them, they get a perspective, and then they understand, and then they know to expect that pain, and then they feel better about it, okay? Sometimes these patients will have a post-operative flare-up, so sometimes they will need a post-operative antibiotic. So again, let the patient know that they may need an antibiotic or a steroid to help them in the aftermath of their treatment. And again, the minimal treatment for symptomatic apical periodontitis, that tells me that the PDL is affected. So you have to get all the way down the canal in order to make sure that they will be 100% pain-free when you're done with their treatment. Your acute apical abscess, this is your patient who's swollen. They definitely need an antibiotic. This is probably the time when I will do 2 steps, because I want to make sure that that canal is nice and dry. A lot of times there's a lot of exudate that's still coming up and I can't get it dry. So sometimes I'll do an IND because maybe that's all the time that I have. I don't have time to open the tooth. My preference for me is to open the tooth and do the IND. I especially like to do open the tooth if I'm not suspecting any drainage from the IND. And I will do the pulpal debridement first and then the IND, because I don't want them to be kind of drinking that stuff under their rubber dam if I do the IND first. Okay, so my preference is to do the pulpal debridement first and then the IND. Again, letting them know, once people that are swollen out to here, it takes several days. And I say a minimum of a week to really look like yourself again. And again, letting them know that that's going to take time is really important in managing their expectations. Otherwise, they think for the days after that something's not right. Now, I included the chronic apical abscess here because I want to make a good point of it. Somebody with a sinus tract is not an emergency. Even in a normal day, somebody with a sinus tract is not an emergency. They may have a little palpation pain when they press on that pimple, but these people typically don't have pain because all that pressure, all that pus and that drainage is allowed to drain out. The body found that pathway of least resistance and all that stuff came out. If you try to mess with that homeostasis that's been established by your body, you're actually going to close that gate and you're going to increase the pressure and then flip the person into an urgent situation. So let that fistula be the antibiotic. Those are the people that can be handed the referral slip and they can make their own appointment with the specialist. They do not need same-day emergencies, and remind the people that that sinus tract is their friend. A lot of people get nervous about having an active infection inside. However, during this time, it's really working to their benefit. So never, ever is a chronic apical abscess a true dental emergency. They need treatment, but it's not urgent. Okay, so let's talk a little bit about pain management now that we've gone through the diagnosis, and I hope that all makes sense. So if you feel like you really need to brush up on your diagnosis, then I think that's a great thing to just kind of get back into, revisit, and then really start to implement it so that you can see the impact it'll have on your patient care. So when I do treatment, I always want to give my patients some preoperative medication. There are tons of oral surgery studies that show that pre-op medication has such a great impact on your patient's pain levels after treatment. And so they typically recommend 600 milligrams ibuprofen. Again, do we need to be careful? That part I'm not sure of. I'm seeing mixed things out there, and I don't know what's real news and I don't know what's fake news right now. But this is what I typically do in my practice. 600 milligrams of ibuprofen. If anti-inflammatories are contraindicated in those patients, I will give the patient 650 milligrams of acetaminophen. You always want to stay ahead of the pain. You don't really want to play catch up with pain, and this allows you to do it. So my patients will get a pain med dose before I even anesthetize them. I always like to know how people are doing their anesthesia. What's your standard operating procedure for anesthesia? For me, my maxillary teeth will get 2 carpioles of Septicaine. And my mandibular teeth, I don't use Septicaine on a block. I use lidocaine only. I find it just as effective. I'll give 2 carpioles for my block, and I'll give 1 carpiole Septicaine as a buccal infiltration. There's been several studies that show that this buccal infiltration will actually enhance your block, okay? I teach a lot in the residency program in my town, and I noticed that a lot of my residents will only use 1 carpiole, and they're wondering why they're not getting proper pulpal anesthesia. So in order to get pulpal anesthesia, which is way different than restorative anesthesia, 2 carpioles is a must, okay? And make sure that before you ever start drilling, especially on a lower molar, and especially on a vital case, that you test the tooth with cold prior to that access cavity, okay? And if you find that your patients are giving you tongue and lip signs, but they're still feeling cold, you need to add a Ligajet, okay? The Ligajet is your PDL injection. And I will say, I think this is more effective than using an aspirating syringe as your Ligajet or as your PDL injector. This to me works so much better. It is a little bit of an expense. It's like $250. And I have one for each operatory. Even if you don't love endo and you feel like I will never do endo, I think that this is a great tool for anyone, because you've probably had a patient who you've done a crown prep and you can't finish it because they're not staying numb. This guy will let you get through that entire appointment. When you get it, make sure that you have this housing in it because it's closed. Sometimes the pressure, because the Ligajet, the PDL injection is a back pressure injection, it'll sometimes pop your carpule. So you want to make sure that that glass stays inside. And if that happens, no big deal. You just change it out. Sometimes I have to change out my carpule and my needle and start over because I almost get too much pressure, or I feel like my anesthesia is not really going in. When I do give the Ligajet, I give it in 6 different spots. So I do it on the mesiobuccal, the straight buccal, the mesiolingual, or sorry, the distal buccal, the distal lingual, the straight lingual, and the mesiolingual. So you have to go in each spot, and you should really see some tissue blanching. That's really important. And then I know that that's working, okay? And this injection works right away. In fact, it only allows you for like 20 minutes of pulpal anesthesia. So it's only enough time to get in there and do the pulpectomy part. But once that part's done, you can move forward with your anesthesia, with your instrumentation, because you'll be fine. But you want to do a cold test on your tooth one more time to make sure that this took. But you don't have to go and have a sip of coffee and come back. You actually want to do that cold test right away to make sure it's effective, because you don't want to lose time. Once you feel like this has been effective, you want to get your rubber dam on and start your access. All right, so let's just kind of go over that one more time. When your patient has temp sensitivity only, a pulpotomy is enough. When there's temperature and percussion tenderness, you've got to do a pulpectomy. When there's a necrotic pulp, we call that pulpectomy a pulpal debridement. And when there's swelling, you can do an IND and or a pulpal debridement, okay? For the post-op care, I think proper post-op instructions goes a long, long way. When you tell people what to expect and you can paint that picture for them for the next 3 days, that speaks volumes. It not only manages their pain and their anxiety, but it speaks volumes about you. And then it develops another layer of trust between your patient and yourself. So I highly, highly recommend that. Have a good post-op regimen. So for me, I will tell my patients to take 600 milligrams of ibuprofen every 6 hours for 3 days. And I actually emphasize that it's pain or no pain. Once that pain comes back, it's harder to get rid of. So you want to be on top of it and be religious. If one of their doses is in the middle of the night, like 3 a.m. is when they're supposed to take it, tell them it's okay to sleep through that, but if they can keep a bottle of their meds on their side table, so if they wake up at 4 in the morning, they can take that dose and go back to bed, okay? Some patients are gonna need to alternate with Tylenol, or some patients are gonna need just Tylenol. And again, if they're just acetaminophen Tylenol based, then they are gonna need to know that they're gonna be a little bit more sore and for a little bit longer. And then every now and then for my patients, I will need to put them on an antibiotic and or a steroid. These are my patients where they have some post-op swelling. They really can't bite. Even just grazing their tongue on the tooth really hurts them. And just ibuprofen and acetaminophen are not working, okay? And always, always, always call your patients the next day. Personally, I like to do that myself. I know from experience that my patients really appreciate it, and this is their opportunity to ask me questions that they forgot when they sat up from their procedure. So it's really, really important and such a nice touch. And in the beginning, I really recommend every dentist to do it themselves, because again, you're going to see those trends. You're going to learn what people are going through during their post-op. And you just won't get that experience if you outsource this to one of your team members. And eventually you probably can, but in the beginning, I think you should do it yourself. So this is the flexible pain management chart that we use in Endo all the time. And it's really, really helpful. And you always want to start with the patient who has mild pain. And you can see that's where the 600 milligram ibuprofen is recommended. And that's for the patients who can take your anti-inflammatories. Anybody who can't will take the acetaminophen. And you can take anywhere from 650 to 1,000 milligrams of acetaminophen, but not to go over the 3,000 milligrams. That's the daily recommended dose, okay? If your patient has moderate pain, mixing the two, there's several studies that show because these two drugs work in different pathways in our brain, you're actually inhibiting two different pain pathways. So that's why you're getting a synergistic effect. In my opinion, I like it better than giving hydrocodone, okay? I personally cannot tolerate a narcotic. So for your patients who can't tolerate a narcotic, it really, really, really is effective. If you are giving hydrocodone, just remember that there's acetaminophen in the hydrocodone, so you want to calculate that into your daily dose. And for anyone with severe pain, you want to follow the moderate pain regimen and then add the antibiotic and possibly a steroid. I do tell my patients if they're taking a steroid, they probably don't need the ibuprofen anymore, just because if you can remember the arachidonic acid cycle, sorry if that's too much, the steroid is going to hit that cycle all the way at the top. So all those other things are not even going to be forming, not even the COX pathway. So the ibuprofen is not really going to be needed. So for those of you who are in search of a good post-op instructions, I have given mine on my website. My website is soniachopradds.com. That's Sonia with an I. You can download them for free. You can even brand it for your practice. I have honestly used these post-op instructions and revised them probably a dozen times over the past decade. And they are like word for word what your patient should be experiencing. So if you learn that and you become a good predictor for your patients, it's really going to speak volumes for your patients and how they feel about you. But also it's such a great thing for your patients to take home, because then they can read that before they feel the need to call you. So when do you use an antibiotic and a steroid? So post-operatively, this is when your patient has that periapical radiolucency and they have that chance for swelling, or they have pain along the jawline, or too much pain to percussion. Those are typically the symptoms that they are going to repeat to you that that's what's happening. So keep those in your little, your bank, because you'll see that it gets repeated often. Now, what about right now? What if you have to postpone treatment? Maybe you don't have proper PPE in your office, but that stuff is coming in May, and you want to make sure you're protected before you go in to see your patients. What are some of the diagnoses that you can actually utilize an antibiotic to buy you some time so that you can be safe to go in to see your patients? That's the late stage irreversible pulpitis, your patient who has pain to heat. That's your necrotic pulp, that's your acute apical abscess, and that's your symptomatic apical periodontitis. Any of those, you could probably give an antibiotic and see that your patient is getting relief. Remember, chronic apical abscess, even though there's a lesion, even though it's necrotic, it has a sinus tract, so you don't need to give those patients an antibiotic. And what should you prescribe? Again, this is totally your choice, but I would say that the things that we use in my practice are either clindamycin 300 milligrams. And again, it says QID right here, but it could be TID. It's totally up to you for 7 days, or Augmentin 500 TID for 7 days. I do always recommend that you use a probiotic when you give an antibiotic, even if it's as simple as amoxicillin. I know some people are really hesitant to use clindamycin because of the risk of C. diff, but in my experience, I've seen that more people have gotten C. diff from amoxicillin. So I think any antibiotic can cause it. I personally like clindamycin because I get a nice penetration into the bone, which I feel like is necessary, and I feel like it's the most effective for that. But my partner uses Augmentin and he likes that better. So it really is what you prefer. And don't forget about the Medrol dose pack. And a lot of times I'll tell my patients to use that Medrol dose pack. It's 6 days. And the first day, if you take all of those pills all at once, I've seen people get into, feel so much better after just 2 hours. So it can be really, really effective if they take all of the pills at one time. Not all 40 pills, but just day one. And a lot of times I encourage people to take it early in the morning, because if they take it too late, then they'll be up at night and they won't be able to sleep. You do have to be careful with patients with uncontrolled diabetes, though, with Medrol dose packs. Now, if you're looking for a good probiotic to go with your clindamycin, I think that the Saccharomyces boulardii is a good one. You can find this online. You can find this at any Whole Foods or health food store. So this is the one that I usually tell my patients to get if they're taking clindamycin. Again, I don't prescribe antibiotics that much at all, but when I do, I make sure that they're covered. So I love to tell tooth stories, and so I'm going to show you a few cases that I actually did during this pandemic, week 1 of this pandemic. Usually I say that there's only 2 types of patients who really constitute a true dental emergency, okay? This is on a normal day, okay? This is the patient who needs a sip on water to relieve any pain to heat. Their own body temperature is elevating the temperature in their tooth, and they take a sip of water, and you know who they are because they're sitting in the operatory with you. They're trying to tell you their pain, and mid-sentence they stop and they say, hold on, I need a sip of water, and they take that sip of water. That, to me, is a patient who has not slept in several days, and they really can't get any relief. Will an antibiotic work? Probably. But again, if we can help them right away, that would be great, because I've had a toothache and nobody should have to experience that. So that's why I'm still going to work and why I think it's important to still be able to see people. You also have the patient with either a necrotic tooth or a tooth that's been previously treated that they have intense pressure. And these people are typically pacing your waiting area. They just can't think straight. You almost have to numb them up to do your evaluation because they can't even comprehend what you're saying. And they would gladly have you take out their tooth if that was the only treatment that there was, but there isn't. You can oftentimes get in there, and once you pull out that gutta percha, you see that pus coming through the tooth. And once you relieve that pressure, they feel better. But at this level, an antibiotic can't get into their system fast enough, okay? So typically these are the ones that I will say, like, no problem with them getting into my practice on the same day if maybe I'm already seeing 12 patients. I have no problem working them in. But there's other ones that can really be managed with proper pain medications to buy them time and to get into your schedule when you really have some time to deliver that quality care. So here's patient 1. This patient had already gone to the emergency room, and we know that our part of our job right now is to keep people out of the emergency room. She was a young lady. She was 24 years old. She had pain on the upper right side. When I did my testing, I saw that percussion was about 3+ on tooth number 2, and everything else in the quadrant was normal. If you look closely, you can see a periapical radiolucency on the palatal root of number 3. So your eye might go there, and you may automatically assume that tooth number 3 is the problem. But it wasn't. Tooth number 2 had no response to cold either, and that was a tooth that was necrotic. They both need treatment, but tooth number 3 has been like this for some time. It's stable, it's asymptomatic, it needs treatment, but we can push that treatment out to June. So I was able to diagnose her with a necrotic pulp and symptomatic apical periodontitis number 2, and previously treated an asymptomatic apical periodontitis number 3. See how I have both of those diagnoses for both teeth? And I will have that before I even start anything on a tooth. And I'm now gonna let that guide me through my whole process. So here's the pre-op. I always take a bite wing. I want to make sure that crown margins are good. And if I am going to suspect that a crown is going to come off during treatment, I want to let them know that before I start it. Otherwise, they're going to think that I did it. I have a cone beam, and I could clearly see the periapical radiolucency on the palatal root of number 3. And you can see a tiny one that's starting on tooth number 2. In the axial view, you can see that there's a missed canal on tooth number 3. The MB2 is never treated. Okay, so clearly a problem with number 3, but that's not our culprit tooth today. So this is a great example of a patient with multiple issues, but you have to solve their chief complaint first. So I treated tooth number 2, and I plan to treat tooth number 3. So in this case, I just wanted to go over the pain management must. What do we have to do at a bare minimum to make sure that this patient is comfortable, that they don't keep calling us because they're still in pain, and then we could keep them out of the emergency room. In this case, you have to do a full pulpal debridement because the tooth was necrotic. Okay. I also want to remind her that she could still swell after treatment because there were lesions that we could see on the cone beam. And that could happen even up to 3 days later. So sometimes swelling happens not on day 1, but it happens on day 2 or day 3. And that also can be concerning. So you tell the patient to expect it for the first 3 days. It's very variable. And again, you're just managing your patient's expectations in that moment, and then they feel better about it later on. And then if nothing happens, they're super happy with you and they think you're a god. So it's really a win-win. Let the patient know that chewing is not going to feel good. It's actually going to feel a little worse before it gets better. I recommended retreatment number 3 in the future. I gave her proper medications. I gave her 600 milligrams of ibuprofen every 6 hours for 3 days, pain or no pain. I did prescribe her clindamycin and Medrol. I didn't tell her that she needed to take it, but I did prescribe it. And I said, hey, you can pick it up. You know, there's all these shortages of toilet paper and medications and all this stuff. So I wasn't sure what was going to happen to the antibiotics. So at that point, because there was so much uncertainty, I said, hey, why don't you just pick up this medication? You may or may not need it. Feel free to call me. I'm going to call you first, but feel free to call me if you have any questions or feel like you're not sure if you should take it or not. I, of course, gave her my written post-op instructions, and I always call my patients the next day to see how they're doing. Patient number 2. This was a 52-year-old man. He was the guy sipping on the water, and he like mid-sentence, he was just like, let me take a sip. He couldn't finish it. We actually treatment planned him for a root canal 4 months ago, and he never got it treated. He was very percussion tender on tooth number 4. There was no response, but he did have pain to heat, and cold was relieving the pain. And I think that that was his chief complaint maybe the day before, but by the time I saw him, I could tell that he was a little more necrotic than he was over the weekend. So I diagnosed him with a late stage irreversible pulpitis and symptomatic apical periodontitis. Now, I could also diagnose him with a necrotic pulp because there was no response to cold, but I knew what was happening because I was watching him in the chair. And that late stage irreversible pulpitis is not like an AAE accepted definition, but so I guess you could put / necrotic pulp, and I think that's still acceptable. So here's the pre-op radiograph. You can see it's an important tooth because we really don't want anything to happen to these adjacent implants. This is his bite wing. You could tell he couldn't really bite down without any discomfort, so you can't really see what's going on that maxillary arch. And then the post-op. You can see I got a nice little lateral. And I am finishing all these cases just because it's just easier for me to do that. Plus, I want to plug this with a composite. So because I don't know when patients are going to get back to their dentist for the permanent restoration. I don't know how long the pandemic is going to last or these office closures. So I'm trying to stabilize people as much as possible and minimize their time out of the house right now. All right, so in this case, what are the pain management musts? Well, it's a late stage irreversible pulpitis. I need to get the pulp out, okay? And this is why I'm making that differentiation from a necrotic pulp in this case. Because if I didn't find all the canals, and I just did a pulpal debridement and I didn't do that full like pulpectomy and made sure all that vital tissue was out, he'd probably still have pain, okay? And he was already super tender to percussion. So I know it's still gonna be super tender, if not worse, after treatment. So I wanna let them know that, okay? I remind them when I'm doing a vital tooth, hot and cold shuts off right away, but percussion lingers for a few days. Okay, there was no lesion, there was still some vitality, so I didn't give an antibiotic in this case, and I just told him to take the ibuprofen around the clock for 3 days. I gave him my written post-op instructions, and again, I called the patient the next day, and so far all of them have been doing well. Patient number 3. This was a 56-year-old woman. She said that it hurts even to brush her teeth. Her dentist had been watching this tooth for some time, and of course now it flares up. She had 3+ to percussion. There was no response to cold, and you could see that her tissue was red inside and it was starting to swell. Her diagnosis was necrotic pulp and acute apical abscess due to that swelling. Here's the pre-op. You can see that this bone is starting to resorb. There's the bite wing and the post-op. And again, let's go through the pain management must. You have to do a full pulpal debridement since this tooth is necrotic. She looked like she was going to swell. So that emphasis was even more on this patient than the other patients. I let her know that chewing was not going to feel good for a few days. I gave her proper medications. I actually did want her on antibiotics, so I prescribed her that and I instructed her to take that. And again, the 600 milligrams ibuprofen, this is just, again, a system, a standard operating procedure. This way you know what you're giving all the time, you don't sway. If anybody calls and gets one of your team members, they know your pain management system. They can ask questions like, hey, are you taking the recommended dose? And if they say no, then they say, well, why don't you do that? So your team also should learn these things so that they can help support your protocols. And of course, call the patient the following day to make sure they're doing well. So a lot of us have been, forced to close our practices. A lot of us need to kind of triage over the phone. I think what's even better is if we triage via video conference so we can see our patients, because sometimes swelling to a patient is not swelling to us. So we can make our patients feel better that, oh, what they're experiencing or what they're seeing is normal. I think having remote access to our dental softwares right now is more important than ever, especially your FMX, so you can kind of help yourself make a diagnosis because you have some imaging which might not otherwise be available anywhere. I will say that this is one way you can really help your specialist, is even if you have an FMX or PA and a bite wing always, that is not firm right now, at least share that with your specialist, because even if you're not doing the root canal and you're having somebody help you, that little bit extra information is so important. And it'll allow us to gain a little bit more perspective on what's happening in that patient's mouth. Get really good at your diagnosis and listen. We all have this amazing skill of listening. And when we do that more, and I think this is good time to practice, you're gonna see that the same tooth story shows up over and over and over again. And you're gonna know exactly what is the treatment for that, okay? So really get good at your diagnosis right now and really get good at your listening. It's a free tool that we all have that we need to utilize a little bit more. You can set up teledentistry in your office right now. You can use calendly.com, you can use Zoom, you can use doxy.me. There's so many ways to set up teledentistry for your patients right now, and I would highly recommend that you use it, and you're probably going to use it moving forward. It's probably such a great way to really help your patients. I kind of think about it in the terms of a tooth avulsion. If a patient can get instructions on the soccer field of how to put that tooth back in, that is such a huge service that you could do for your patients. So think about ways that you can incorporate teledentistry in your practice. If you're just talking about testing and like really understanding the patient's pain, it's simple. Like get a chopstick and have them do a bite test. Use that same chopstick and tap on the teeth and guide them. Do it on yourself, and then they can repeat, and you can watch their face and see if they're really having a response, a different response to that tooth versus another tooth. And then, you know, just from that creativity, you can make a diagnosis and you can medicate accordingly. And again, buy yourself some time to when you are either reopened or you have the proper PPE. And I always recommend that everybody get paid for their work. So you can, right now, I think most insurance companies are allowing teledentistry. So you can submit a claim using the 140 code. Plus you will use the D9995. Sorry, I know this is US, I apologize, or D9996. The difference in those are the synchronous or the asynchronous. The 95 is synchronous and the 96 is asynchronous. The difference is the synchronous is when you are doing a live consult with your patient, and the asynchronous is when the data has been collected and it's been sent and you're looking at it and it's not in real time. So typically you're going to use the D0 140 plus the 9995 to submit your claim. But it's really a great time to see if teledentistry will work for your practice. So that's all I have for you guys today. If any of you want to connect with me, you can find me on Instagram at Sonia Chopra DDS. Remember, that's Sonia with an I. I'm also on Facebook at Sonia Chopra DDS, Endo for All. My email is sonia@soniachopradds.com. And I have tons of free resources on my website, soniachopradds.com. And there's a bunch of downloads. You can get the post-op instructions. There's a lot of videos that are free as well. I do have my e-school that Effie had mentioned in the beginning. It is an online endodontic program for general dentists to really amplify your endodontic game. Right now, because we are all in quarantine and with not much to do, I am offering it at a discount at $9.97, and there's free coaching calls for the month of April, and I'll probably extend this into May if this is lasting longer. So get in if you'd like. I understand that this is not the best time for everybody. So I just want to emphasize there's a bunch of free stuff on my website as well. And that's it. Thank you, thank you.
Okay. Sonia, thank you so much for the excellent presentation. I, as a prosthodontist, learned quite a bit, and now I remember why I don't like doing endo. So congratulations on giving a very informative talk, and clearly by the amount of questions that we have, you know, it really struck a chord and it really resonated with a lot of people. So in the interest of time, I think we'll spend about 5 to 10 minutes, and certainly won't be able to get through all of the questions, but we'll try to do our best to answer some of the ones that have recurred. One of the questions that keeps coming up is 1 appointment versus 2 appointment endos. What's your preference? And there's some specific scenarios that were presented, but maybe you can just talk about it in a broad sense.
Sure. Well, I think whether you do it in 1 visit or 2 visit is dependent on a lot of things. I think one of those things is time, and that's why I think triaging is important, right? Because sometimes, you know, you may have time to finish that tooth on a different day when you have 2 hours versus 30 minutes. And so pain meds can help you get that patient to that spot. So I let patients know I can start your treatment and get you out of pain, but that's all I have time for. So time is a big factor. Obviously, difficulty is another one. Sometimes root canals are even hard for me, and I have to stop. And I think that's the beauty of endo, because sometimes I'm like, okay, I can't find that canal. I just need to close it up and come back to it another day. And I love that about endo. Right. I love doing 1 visit endo. I would say my practice is about 90% 1 visit.
So Dr. Chopra, for example, assuming you have the time, this is, so it's a very directed question, assuming you have the time, and the scenario is, for example, either the patient has a sinus tract or facial swelling, or chronic necrosis with a large lesion. And assuming that endo so what did they write? They said, assume all canals are instrumented to completion and dry. Can endo be completed in these 3 scenarios in 1 appointment? I guess the question is it better to wait if they have these acute presentations?
So a sinus tract, yes, I do those all day long in 1 visit, okay? If they're swollen, if they're traveling, probably, but those are ones, and I think I mentioned that in the presentation, that I prefer to let them get back to normal. I have a little bit more control over the situation if I do it in 2 visits. So typically, if it's still wet in the canal, I won't. If they're swollen, I'll do it. Those are really the 2 reasons why the tooth would prevent me from finishing in that day, if that helps.
Okay, for sure.
Yeah.
Another question we had was, how do you test for cold over a crown? So how do you deal with the tooth that's crowned and the patient presents with some pain? How do you deal with that?
I don't feel like a crown is limiting my cold test ever. Okay. So what I do like to do, because sometimes you'll get no response and you'll think, oh, is it necrotic or is it the crown? Okay. Find another tooth in the mouth. So if you're doing number 3, find another first molar with a crown, if there is one, or just another molar with a crown, and see how that tooth responds. Obviously, it can't have a root canal, but if it has a positive response, then you know that that tooth with the crown should have a positive response. And put that cold test on the crown margin by the gum. Okay, it shouldn't, obviously, from a occlusal aspect, that's not going to work. And I find that a lot of people use a Q-tip to do the cold test. You'll never get a good response with a Q-tip. So throw that out and get yourself a cotton pellet, put it on the end of a college plier, and make sure that that cotton ball gets really cold where you see a lot of steam coming off. And this is a test where you want to be 100% positive. You don't want to have any question whether it's a positive or a negative response. And that sometimes means that you have to make it a little uncomfortable for your patient, and you have to be okay with that.
Yeah. Okay. Excellent. I think we'll take one more. Do you recommend, no, hold on. Do you use calcium hydroxide in an asymptomatic apical periodontitis? Does that make sense to you, that question?
Sure. If I'm not doing a 1-step, I will always put calcium hydroxide in a tooth, no matter what the diagnosis. I'll never leave a tooth empty.
Okay, excellent. Based on the amount of questions we have, I think that your website is probably an excellent resource for people to connect with you. You've graciously extended some discounts and your time in consultation. So I would say to those of you whose questions we didn't answer, because there are quite a few that didn't get through, I'm sure Dr. Chopra will be willing and welcome any input or any questions that you might have. Questions about fractures and vertical fractures and diagnosis. Again, I'm sure your eSchool can also address those. So I will direct people to your website.
Awesome.
So again, Sonia, thank you so much for your contribution. I think you had a record number of attendees, a record number of people signing up, and for people to sign up to Endo, we clearly know it's a very hot topic. So we appreciate really your time and taking away time from your family and from your work to be here with us. So on behalf of myself and Women in Dentistry, I do thank you very much. And now I'll just conclude with a few housekeeping issues with regards to Women in Dentistry. We have a number of other programs on track. In a few weeks, we have Dr. Reena Talwar, who is an oral maxillofacial surgeon, talking about how to manage, I forget what her topic is actually, I think it's around periimplantitis. In about a week or so, we were doing a co-hosted program with the Canadian Dental Association. So again, we're finishing up the finishing touches on that program. So please stay tuned on social media, subscribe to our mailing list, we'll get you information there as well. The other thing we wanted to mention is that some people have been asking about CE credits. I do apologize. We have been a little bit delayed. There have been some technical glitches, but we will get them to you within 2 weeks of the program. And they are for Canadians so far. So because this webinar business started so quickly, we don't have it figured out yet for the US. So we're working on those applications. But any Canadian application will be received. So again, I thank you for joining us. I thank you for taking the time out of your schedule to sign up to the Women in Dentistry series. Again, I encourage you to follow us on social media, like us on Facebook, follow us on Instagram at Women's Dentistry. And again, on behalf of myself, Dr. Chopra, the entire Women in Dentistry team, thank you, stay safe, and we look forward to seeing you at our next webinar next week. Have a great day. Bye.